Hi, everyone. Thank you so much for joining us this afternoon. We're really excited to have a great panel discussion around using AI to streamline post-stroke patient journeys to cardiology. My name is Jamie Strauss. I am the Chief Clinical Officer here at Viz AI, and I'm delighted to be joined today by two amazing leaders in their space, Dr. Brett Meyer and Dr. Jonathan Su. If you both could go ahead and introduce yourself and give a little bit of an overview of the patient population that you see within your institution.
First of all, thanks for having me. My name is Brett Meyer. I'm a professor of neurosciences and a stroke specialist and a researcher here at UCSD for the past 23 years. I'm the clinical director for the enterprise for overall telehealth and the telestroke director for the past 20 years. I'm the co-director of the Stroke Center, which is more of a clinical operations job. I'm very operationally savvy. And I have been the director or lead for operationalizing our Viz implementation for hyperacute stroke. And our experiences show we improved our KPIs significantly. We'll talk about that, I'm sure. I'm a stroke specialist. I work on the wards, take care of somewhere between 500 and 600 patients, stroke discharges per year, have a busy outpatient clinic. And I would say probably 15 to 20% of our stroke practice ends up being cryptogenic stroke.
Great. Thank you so much. Dr. Su, can you go ahead and take some time to introduce yourself and give an overview of your patient population?
Sure, I'd be happy to. I'm Jonathan Su. I'm a cardiac electrophysiologist at the University of California, San Diego. I'm an associate professor and clinical researcher, and that specializes really in arrhythmias of the heart. That's what electrophysiologists do. My clinical work is, I have a busy outpatient practice seeing patients with all types of cardiac rhythm disturbances. I also have quite busy procedural volume performing ablation procedures, cardiac implantable devices to treat and detect arrhythmias. And one of the most common cardiac arrhythmias that we treat as electrophysiologists is atrial fibrillation. It's really an area of significant clinical experience, expertise, and interest for me. And one of the most devastating implications of atrial fibrillation is cryptogenic stroke, which is why we're here today. As someone who really has a profound interest in clinical research in stroke as an outcome, we want to reduce stroke risk with oral anticoagulation, left atrial appendage occlusion, early detection of atrial fibrillation, and really had a profound importance of devices such as implantable loop recorders to detect AFib, particularly in cryptogenic stroke patients with helpful tools like Viz. And that's what we'll be talking about today in this webinar. So really a pleasure to introduce myself.
Thank you both so much for those great introductions. Before we get into the really discussion point of our webinar today, I would like to take some time and give an overview of Viz for those of you that are not familiar with us. So at Viz, our main focus is to increase access to life-saving treatment for patients. And we know that less than 20% of patients receive the right therapy in many diseases. And we aim to focus on those diseases that are often misdiagnosed, underdiagnosed, or really require complex care coordination across multiple decision makers and multiple teams to get the patient to the right specialist in the right time to get the appropriate therapy that they need. So Viz is adopted by over 1,300 hospitals worldwide. And we really do aim to focus on increasing access to life-saving treatments. And this is done through not just the AI, it's more done through the care coordination and the workflow that happens with the AI, starting and activating that workflow. So if you think of Epic as your system of record, where it is a repository for a ton of data that the patient in their healthcare journey, and it's capturing all of those data points, you think of Viz as the system of action, because while that data is there, the action that needs to happen to trigger that patient through their workflow is where Viz can play and have a huge impact. So how do we do that? We ingest all types of healthcare data, and that includes imaging modalities, CT, MRI, ECG, echo, EHR integration, pulling in those data points from the EHR and really pulling together what we need to really start doing the AI analysis for that patient. So we then ingest that data, send it up to the cloud, We analyze that data in our cloud, and if there's a finding, it then sends this alert down to the whole care team at one time. And this is disease specific. And from that, the care team is really then able to receive that alert that's to the most appropriate specialist that needs to lay eyes on these patients, or the clinical research team that there may be looking to enroll in a clinical trial. And at that time, the care team is notified and alerted, and they're really able then to enable therapy. And when we talk about enabling therapy, it can be getting them to the right specialist for a procedure, getting them to the right physician for the right drug treatment that they need, or getting them to the right clinical research trial to get them the most appropriate access to care to help improve patient outcomes. So when you think of Viz, you think of it as the enterprise platform. And the things that we really focus on at Viz is detecting disease earlier and in more patients. So it's identifying where there is rare disease or underdiagnosed or misdiagnosed. And not only do we identify it earlier, we really look to capture more patients that may be in a rural community, may not be detected or identified as a patient having this specific type of disease. We streamline and track care pathways. So with easeability in the tool, moving that patient through their workflow to get them on the right path to get the most appropriate treatment that is, identified in the guidelines and by the specialist of how these patients should move through the healthcare system. And that's done by using those alerts in the care coordination and workflow triggers to get the right patient to the right specialist at the right time in the medical moment of truth. So when that patient, there is a decision that is needed on what should happen with that patient, the right people are looking at that patient at the right time. And when you can see is we're across a variety of disease states. So we started in neuro, and that's really where we got started in stroke. And we're going to talk a little bit about the stroke use case and the real world evidence that we've been able to generate. But now we've gone broad across vascular, cardio, radiology as a whole, oncology, chest, spine, and ortho. And we've expanded the modalities and offerings that we have to include all different types of patient data, whether it's imaging, whether it's notes from the record, whether it's lab values. And we have a multitude of integrations across all health systems where it looks at EHR, PACS, single sign-on, radiology reports, work list. And the way that we kind of break out our platform and solutions is we have our clinical workflows, which is our Viz care pathways, which we're really going to talk today about one in particular around cryptogenic stroke. We also look at and have a lot of engagement in clinical trials. So looking at Viz Recruit, which is our research platform, which 24/7 is screening patients, not just in the hub or the quaternary center where the PI is, but all of their surrounding facilities out into the community and spokes where those patients may not be identified as a candidate for a clinical trial. We now have AI screening 24/7 out into the community. We also have support for the healthcare providers where you can easily share cases that are de-identified with your clinical specialist that you work with, whether that's on the med device side or the pharma side, or the individuals that really need to come in and help you make decisions and support care for these patients. And then the final pillar that we look at is analytics. So taking all of the data and making it meaningful for the health system to identify where patients are moving through workflows, where they're getting stuck, where they are getting screened for clinical trial enrollments, where they're getting enrolled, how is that working and how is that happening, and collating that data to really tell the story of the patient journey. So we started in stroke, and that is really where we made our first impact. And we have tons of publications and real world evidence on the actual clinical outcomes that we've been able to make for patients. So much so that we were awarded the first ever new technology add-on payment for an AI solution because of the patient benefit and the clinical impact that we've been able to make. And when you think about stroke, it's such a debilitating disease that we really focus on time to treatment so much because time is brain. But beyond that, we know that if we treat patients quicker, they have less likely to have a debilitating disease for the rest of their life. So through our partners and our physicians that we work with, we've demonstrated a 23% improvement in patient outcomes. And what that means is patients that previously maybe did not get identified for treatment early enough would have a lifelong disability and maybe have to spend the rest of their life in a nursing home with 24/7 nursing care are now able to go home. We also have 87 minutes saved, right, across multiple centers where we've seen really well-established comprehensive stroke programs. And we're going to talk to Dr. Meyer about that today. And even how Viz early on in a really well-structured, well-run comprehensive stroke center was able to make an impact on their program. From a resource utilization, we've seen 3.5 days in reduction in length of stay. And what we saw in COVID was, the capacity in the ICU and bed availability was very limited. So ensuring that we are moving patients through and showing resource utilization and using them for the sickest patients, because now we've identified disease earlier and these patients do much better and don't need this long time in the ICU. And we've seen, increase access to care. So when we look at the number of patients who should technically receive thrombectomy, we were, a lot of areas are very underserved. And now we're seeing the ability that more patients have more access to care to get the right procedure that is life-saving for them. We're really going to focus in today on cryptogenic stroke. So for us, it was really a natural extension of, we looked at the acute phase of stroke, and then there became this unmet need that we identified of these post-acute stroke patient workflows and what happens to them. There's a lot of interesting publications and data recently that's really come out around cryptogenic stroke care. And we know that 1/3 of strokes overall, ischemic strokes, are classified as cryptogenic. And when we say cryptogenic, we means that we don't know what actually caused that stroke. And we need to work this patient up and move them through their workup to identify the true cause so we can hopefully prevent reoccurring stroke or secondary stroke. We know from the literature that there's days to months for a cardiology consult, whether that happens inpatient or outpatient. And when we get into the outpatient setting, some of the challenges is those patients coming back in for the appropriate follow-up care that they need. And with this, again, we talk about the reoccurring stroke. We know that 25% of these patients will have a stroke again. And we know that we need to prevent multiple strokes from happening, because the more strokes that you have, the higher your likelihood of severe disability. So we worked really closely to develop a tool called Viz Connect, and this is really a workflow solution. And what we're basically doing is taking the stroke care team and having ease of accessibility and ease of a solution that connects them directly to the cardiology team, or as we call it, the heart team. We're going to talk a little bit later, and you're going to hear Dr. Meyer and Dr. Sue talk about the heart-brain team and how those two teams must come together for these patients in order to prevent them from having reoccurrent stroke. So what happens, right? So the stroke team, they're using Viz, they're getting alerts that this patient is a suspected stroke. They're coordinating care in that acute setting. And once that acute moment of that stroke patient is happening, they're then able to start moving them through the post-acute stroke workflow, as we call in the hospital setting. So how am I going to move this patient to identify what is their cause of stroke? That typically goes for a referral for a cardiology consult. You're going to hear some of the challenges that were there prior to Viz Connect, but the care team really directs patient to the heart team within one click of Viz. And when you click on that, it prompts you to answer questions that the heart team needs to make sure that they understand what needs to happen for that patient prior to them leaving the institution. So the cardiology receives an alert. They're able to communicate in a HIPAA compliant way on that patient with the stroke team, and they're able to get the consult completed before they leave, and also then even further setting them up for follow-up in the clinic beyond that. So we've seen a true impact of Viz Connect, where we've seen across 10 pilot sites, we've seen a true bridge of that broken pathway that once existed. So patients referred to cardiology, we've seen not only an increase in patient referrals, but a decrease in time to referral. And this is not an increase in patient referrals. They are the appropriate referrals. So these patients need to be seen by cardio, and we're decreasing that time because of the process that we've kind of streamlined with VizConnect that Dr. Meyer and Dr. Sue will talk about. We've seen an increase in patients consulted pre-discharge, right? Decrease in time to conduct inpatient consults. So it's this, I have all the information I need. I'm going to go now see the patient, make a decision, and move that patient through. And we've also seen increased internal cardiac monitoring. So what that means is patients are leaving the hospital after their stroke, whether that's an external monitor or an implantable loop recorder or a Holter monitor, and they're leaving with the most appropriate monitoring so we can identify if there is an underlying cardiac condition that has caused their stroke, such as AFib. So from a result to date, overall, we've seen a 2x increase in the number of patients with appropriate monitoring. So that's an overview of Viz. I hope you all have a better understanding now of what Viz is. And now we're really going to dive into discussion with Dr. Meyer and Dr. Sue. And what we're going to talk about in this panel discussion is really cryptogenic stroke challenges at their institution, why they chose Viz AI as a solution for them, an impact on care, and how are they thinking about where Viz may be used in other disease states, whether that's in neuro and cardiac. Dr. Meyer, I'm going to start with you. From your perspective, what were some of the historical challenges in referring cryptogenic stroke patients for cardio consults?
Sure. The first historical challenge was getting the process to work, which meant for us getting away from the standard status quo, how we used to do things. We'll talk more about that. The general process was to obtain external monitors or implantable loop recorders. That process was quite straightforward and probably consistent with many other comprehensive stroke centers in the nation. We would basically send off a consult. In our case, we use Epic. We would send off either an inpatient or outpatient consult. In Epic, we would fill out the appropriate clinical forms. We would write down patient has a stroke, ESIS, or embolic stroke unknown significance or unknown source. And somewhere in the Epic console, we write, please place an ILR, or please get an external event monitor. Patient would eventually get that done or not. And the historical challenge was that entire process was extremely slow. It took a long time for it to work through the system. It took a complicated time because there wasn't any ability for us to communicate directly with the provider. We would maybe detail some clinical history in the Epic fields. More times than not, we would not. And it really had no direct line of communication between myself and the electrophysiology provider. On top of all that, there was significant delay in getting to the final determination, getting the patient eventually scheduled. And this is compounded by what we call life happens, which is where the patients have to deal with everyday challenges after their discharge from the hospital, and the likelihood of them being able to attend to their own personal healthcare needs diminishes as we felt as the days, weeks, or months would go by. And we often just simply wouldn't get the results. We wouldn't get the procedure done. But in the end, that's the way it was. And that is sort of the status quo. And we didn't even fathom that there could be another way of doing things. And so I think the long answer to short question about what are the historical challenges is the process was slow, but we didn't know that there could be another way of doing it. We didn't even think that we could be living in a world where things just happened quickly. And I'm sure we'll talk more about that as the webinar goes on.
Great, thank you. You touched a little bit on it, but can you talk about some of the level of engagement between the neurology and cardiology departments for these patients and how you interacted or how you didn't?
Sure. So let me start by saying we are quite lucky at my institution. We have an amazing relationship with cardiology. In fact, one of our clinics is actually in the cardiovascular center. So we collaborate immensely with cardiology. I actually feel that stroke and cardiology are very similar, especially interventional cardiology to some degree. We share numerous patients. We're very collegial. I have worked with these cardiologists for the better part of 2 decades. We both deal with similar cardiovascular or cerebrovascular risk factors. We're both concerned with thrombotic or embolic complications. We both have the same goals to decrease complications of stroke and heart attack. So we're pretty, aligned when it comes to wanting to take care of our stroke patients because, and let's face it, the cause of stroke is often cardiac. And so we have built an outstanding relationship with our cardiologists, particularly our electrophysiologists as well, which the reason I want to highlight is because that's critical. We already had a great relationship with cardiology. And in spite of that, or on top of that, we still, by implementing this program, found immense benefit. And that's on top of a system where we already were able to have a collegial and collaborative relationship with cardiology.
Yeah, it sounds amazing that you already had the heart brain clinic kind of established and that work stream together. What were some of the major challenges or areas for improvement that you identified?
Well, it depends if you're a lumper or a splitter. If you want to lump them all together, it really comes down to two things. First of all, I already hinted at it, limited communication. We had a difficult time using the standard approach that we had before, getting what we wanted translated to the electrophysiologist and then getting the procedure done. The second one I would lump as process hurdles or hurdles in general. We would fill out an Epic request. We'll talk more about that. And then there'd be, I don't know, what felt like a million steps along the process between the time where we sent out a request and the time where the patient may or may not have gotten an external monitor, an internal monitor, the recorder, what have you. There'd be a significant time delay. So we had poor communications because of the systems we were using. Not that they're bad, it's just different. And a ton of hurdles between point A and point Z, which we'll talk about. Nowadays, things are just quite different. We'll get into that, but VizConnect allows us to have direct communication, immediate response. We can get bilateral questions answered between us and the electrophysiologist. We at times, and quite frequently has become the norm, get immediate intervention. And in the end, we get the patient what we think the patient needs in order to improve their care. So I think our biggest areas of concern were in the past, we had limited communication and it just way too many steps in the process to make this system efficient to get the patient what they need.
Thank you for that. And Dr. Su, now that we've heard Dr. Meyer's perspective, I would love to hear your perspective. Did you feel like there was an unmet need in receiving a cryptogenic stroke patient from the stroke team?
No doubt do I feel that there was an unmet need to getting really an efficient consult from the neurostroke department at our institution. And I just think it's something that was probably something that we didn't recognize was an issue before we had VizConnect. Patients are certainly having strokes and certainly having atrial fibrillation, and it could be suspected, but we weren't really getting the evaluation for arrhythmia as they may need for the patient and from our neurostroke colleagues. Obviously, our colleagues in neurostroke are understandably very busy treating and coordinating an acute stroke in a patient's care, and then the very important care. So historically, consults would be obtained to electrophysiology via page, Epic, chat, a phone call, and for a patient where sometimes the consult question was unclear or the communication was not perfect, and the actual request for either an implantable loop recorder or an event monitor was not clear in the consult. So there were really challenges in communication with intermittent consults from our neurostroke colleagues to electrophysiology before we really truly implemented and found success with VizConnect. In the outpatient world, patients were expected to navigate multiple unfamiliar departments and divisions and specialists, including ourselves in electrophysiology after their acute stroke. And really what this tool helped us is to what we wanted to do, which was provide best care for our patients. We really rely on our stroke neurologists to tell us who really needs this type of care. And this tool really helps us communicate and identify the patients that have this as their utmost importance. So it's common for cardiologists to have limited actionable information about a patient with stroke. We're oftentimes not aware that these patients are in the hospital. So we rely on our stroke colleagues to tell us, A, that they're in the hospital, and B, that they suspect an arrhythmia as the etiology to their stroke. Sometimes we find out way too late that this is an issue. So this is really important to realize, to give a patient the best care that they need and they deserve in collaboration with our neurostroke colleagues. So really tools like BizConnect have been instrumental with us helping these patients and collaborating with our neurostroke colleagues.
How have these challenges impacted the cardiology department's ability to provide optimal care for a cryptogenic stroke patient based on some of the challenges that you've previously described?
So some of the challenges we experienced are, first of all, there really had been delays in reaching stroke patients for their needs, really to provide them with the optimal care. Oftentimes, before BizConnect was employed, we often would not hear about a consult until a very late portion of their hospital stay. And it would be quite difficult to manage to fit them into our procedural schedule for their optimal care, such as having an implantable loop recorder implanted or placing an event monitor on them prior to discharge. And these are really important aspects of detecting or attempting to detect atrial fibrillation in a patient with cryptogenic stroke. So oftentimes there was a lot of extra work in order for the cardiologist or electrophysiologist to really help put the pieces together for a consult. And this created significant work in trying to piece together a consult. What was neurostroke asking of us? Did they want a specific monitor or implantable loop recorder? And tools like Viz allowed us to really be efficient in our communication, and allows us to be efficient in our communication as we continue to use the tool, so that the ask from neurostroke is really apparent. And this type of communication, I think, is really important for the care of our neurostroke patients that we collaborate on. Sometimes we don't know why a patient is being why we're being asked to consult on a specific patient, particularly for an outpatient consult. The referral process can be lengthy and unwieldy, and avoiding these obstacles have been really key. And sometimes it's really hard to get patients in for follow-up or know who we need to get in for follow-up. So having the ability to communicate with our neurostroke colleagues has been one of the best aspects of BizConnect in really allowing us to know who we need to focus on and who we need to coordinate care both in the hospital and outside the hospital. Let's be honest, sometimes monitoring had not always been performed, and longer duration monitoring, such as utilizing an implantable loop recorder, which can last 3 or 4 years, and attempting to detect atrial fibrillation in a cryptogenic stroke patient population just wasn't being identified or utilized. And getting the optimal amount of monitoring with an implantable loop recorder to identify these atrial fibrillation patients and get them the proper care, such as oral anticoagulation or left atrial appendage occlusion, is paramount, I think, in avoiding future strokes in this patient population. So it's been tools like BizConnect that really allow us as providers to communicate and get them the care that they need.
Dr. Meyer, back to you. So in the past, can you describe and talk a little bit about what types of solutions or process improvement plans or projects that you've done to bridge the gap in your organization?
I love this question because you use the word solutions. I would say countermeasures, yes. Solutions, no. We deployed a lot of different thoughts and ideas over the years. I think the initial countermeasure was certainly Epic. I've talked about that. You know, when we implemented Epic here, and I've been here a long time, I've been here pre-Epic and post-Epic. When we implemented Epic, our hope was that centralizing all the processes under the Epic umbrella, or any EMR umbrella for that matter, would ensure that things got done quickly and appropriately and centrally. Our experience was not exactly as we had hoped. Part of it because what we have found was the right people may not be in front of Epic at the right times. which, by the way, huge plus for the Viz AI solution, because the right people tend to be in front of the handheld when we send out a consult request. But Epic is sort of not a real-time solution. It's a great centralized repository for electronic medical record and consults and requests and data. It's a fabulous product. I think the world of it, but it really was not a solution to our problem. So then you would say, okay, well, what about implementing Epic Chat or any number of chat solutions? We tried that as well. The biggest problem with Epic Chat was that we had a request for, say, an implantable loop recorder, and we didn't know who the right person was on call for that particular thing. So we would Epic Chat people, but it might not be the right person on call, or the right person didn't get the message. And if that person didn't, if we knew the right person, but that person wasn't in front of Epic Chat, again, time delay. And it was a good try, but it didn't really work in the end. And of course, the final common pathway that I would say we all default to is what I call one-off texting, right? You using a secure pathway, hopefully a secure pathway. You may text your provider from the electrophysiology department. And again, I said, I've been here a long time. I know all these people. I'm friends with these people. But the fact is that same problem came up. I didn't know if I should be texting the person who's on Monday or the person who's on Thursday. And it led to some confusion, not knowing who we should be texting. Certainly, we don't want people working outside an approved HIPAA compliant solution. So encrypted texting was certainly encouraged. But in the end, we had lots of countermeasures. I wouldn't say we had many solutions. Luckily, we were using Viz for another purpose, which I'm sure we'll get into. And it just sort of ended up being a natural solution to our problem.
So you talk about the countermeasures. Of those, what worked?
Well, if you asked me a year ago what worked, I would say everything works. It works just fine. Well, at least fine enough. And that is something that I shake my head at a lot, because it did work. It worked to the degree that I thought the system allowed. Only retrospect, having taken the leap into this system, I guess, was I able to see that it didn't exactly work as well as it could. The system was complicated. I guess the results speak for themselves in that we deployed the Epic solution and any number of other solutions, and I could count on one hand how many implantable loop recorders we got done in a year, as opposed to now where we're doing 13 consult requests per month. And so I would say what worked, not very much. What didn't work, or why it didn't work, I would say I touched on a little bit, but there are, in my mind, about 3 reasons why it didn't work. The first is, as I said, it's complicated. We put in the order, we put it off, get an authorization, goes to clinical staff, it goes to an MA, it eventually gets to a provider. The provider may or may not understand the request, may or may not have all the data, may or may not get the patient scheduled into clinic, eventually get into the right clinic. It just took a long time. It was really complicated. The second is that there was just no way for us to communicate well in a sort of asynchronous manner to talk to the electrophysiologist. And I already mentioned the third thing. It didn't work because life happens. And one of the things that I would like to go back to my prior self and say, hey, there is a world where you can get your procedure done that you think is necessary, either implantable or an external, prior to a patient leaving a hospital, because once that patient leaves the hospital, life tends to happen and life gets busy and it's hard for us to take care of ourselves. We have other obligations, we have other responsibilities. So what we tended to do was just default to what I'm going to call a serial process, where people were in the hospital. We didn't think we can get an implantable loop recorder and external monitor before they were discharged. So we just took the path of least resistance, placed the external monitor, sent the patient home, and hoped for the best when they would see their outpatient cardiologist. And realistically, that's the exact opposite of what we want. We don't want a situation where there's a delay for patients to get their monitoring, their cardiac monitoring, because the fact is, as a strokeologist, we need as much cardiac data as possible for our ESUS patients to determine whether or not they are going into atrial fibrillation. It may take us 3 years to get that data. I certainly don't want to wait 3 months for them to get to an electrophysiology appointment.
Thank you so much. I'm going to stay with you, Dr. Meyer, too, because you were a really early adopter of the Viz platform for stroke in general. Can you talk a little bit about how you were using Viz before adopting Viz Connect and that product line?
Sure. Can I talk a little about how I was using Viz Connect? Well, yes, I could talk a lot about how I was using Viz Connect or the Viz product before Viz Connect. So first of all, we are a very robust comprehensive stroke center. We have a strong hyperacute neurointervention pathway. We've been doing it for many, many years. We ended up going to the Viz solution in January of 2021. So we've been operational now for 2 years with what I'm going to call the new system. Similar to the Viz Connect, there was a similar pathway with immediate communication to, in this case, our neurointerventionists and our radiologists. We'd have immediate access to the image review. We'd have advanced CT imaging. We'd have the central communication pathway that I talked about, HIPAA compliant, in order to discuss with the neurointerventional team about large vessel occlusion patients who needed acute thrombectomy. So this is an acute version of what turns out to be a less life-threatening and emergent scenario, which is the Viz Connect solution. But it really is the same concept. I need my provider discussion, and I need it to happen with the right people quickly, easily, without complication. So we deployed it to the bunch of hyperacute teams. UCSD, I think we have over 250, 260 people deployed, from stroke to neuro IR to the angio teams, neuroradiology, neurocritical care, the neurology residents, nurse practitioners, transfer center, registration. We have a bunch of teams that are all deployed on the hyperacute pathway. Patient has a stroke with potential large vessel occlusion. We notify the system, and the right people can make the decisions about whether that patient needs embolectomy or thrombectomy, or even transfer for the evaluation of possible embolectomy at that time. We went from a fragmented communications plan and complex pathways to what I would say is a simple, streamlined solution where everything was at our fingertips. Now, admittedly, I'm a little biased because I deployed it and I operationalized it. So if it's good, it's my fault. If it isn't good, it's someone else's fault. In the end, the proof is in the pudding, because our data on that Viz implementation, just published in January in AJNR, showed a 32 to 39% improvement in thrombectomy time metrics. And this is in a comprehensive stroke center that was already quite robust at doing our processes. So in short, we used it for acute intervention. It was simple. It was easy. It got us improved KPI metrics. And in the end, it was just absolutely life-changing because it simplified our processes.
Great, thank you. So you were already using the Viz platform. Now, we come out with this new Viz Connect. Can you talk a little bit about the implementation and process of implementing that and getting the connection with the cardiology team? And were there any challenges?
Yeah, it's a good question. It was relatively underwhelming because the process was super straightforward. I'm sure there was some customization on the back end from the Viz team. I'm sure that there was a lot of work that went into it, but for the providers, it was pretty seamless. We had a need. We had a new group, which was the stroke team and the electrophysiology group. We just told Viz who the people were in electrophysiology. They gave us a new button, a nice little button that said Heart Team, and we clicked the button and started using it. It has excellent prompting. It tells you when to, what team you're trying to activate. It gives you radio buttons to help you do quick data entry, so there's not a lot of work involved with it. But in the end, it was turned over to us. We opened up the handheld. We had a little button there. We clicked it. 2 minutes later, an electrophysiologist replied, sure, happy to do an ILR for you. And it just worked. And that's the best part about this is that it didn't require a lot of training and teaching and education. It just was something that worked, which is great.
Great, thank you. Dr. Sue, going to turn it over to you. What made you want to try Viz as a workflow solution?
Look, it's basically our amazing neurostroke colleagues, and they're the ones that really implemented this tool. And look, we just really wanted to help our colleagues. They're great, but they're busy, as are we. And they have a lot to do to coordinate the care of these acutely ill patients that are coming in with neurologic disturbances or stroke. And that's a tough job to do, and we're respectful of that. We want what's best for all our patients, including them, and particularly in the patients that they are suspecting an arrhythmia such as atrial fibrillation that could be the reason for their stroke. You could understand why it's really this devastating complication of atrial fibrillation, if it is from atrial fibrillation, would want to be detected. So the short answer is our neurostroke colleagues wanted us to use Viz to communicate as a workflow solution, and it worked. We implemented it. Number one, our communication improved. Overall, we just were able to collaborate and talk more, whereas we were otherwise before VizConnect in our silos. Number two, we knew what they wanted. The communication portion of the app allowed us to use an environment that was very natural, that didn't require training, and they were able to communicate exactly what they needed in their console and what they wanted. And number three, we could provide really actionable requests in a very timely manner, sometimes within minutes. And this was really key both for their day, neurostroke physicians and care providers day, and also our day in regards to seeing a consult or performing a procedure.
Thank you so much. And what were you looking for that solution to deliver? Can you talk a little bit about some of the expectations that you had?
To be honest, I had really no major expectations for the solution to deliver. With experience, it just really delivered. I was somewhat surprised, I'm not going to lie. Didn't even realize there really truly was an issue with communication, or that there needed something to be ameliorated in the consultations that we were providing. And it's ironic because what I realize now that the tool is in place and our communication is so much better through this tool is that it's so key in the care of our patients that have acute strokes where AFib is suspected. That something as simple as communication allows the patient to get a procedure or intervention that is very important, such as ILR implantation. Really, I can only imagine how communication could be really helpful in all realms of both what we do in arrhythmia care for our cardiac patients, but I would imagine this tool is even more profound for neurostroke doctors like Dr. Meyer in really providing what they need to provide for their patients in all aspects of their stroke care.
Great. Dr. Meyer, I want to talk to you a little bit about the impact that you've seen. Now that you've been using VizConnect for a little bit, can you talk about some of the greatest benefits of VizConnect at UCSD?
Sure. There's a lot of them. And I'm going to go back and I'm going to continue to say a couple of the themes that we've talked about. The first is that it just literally removed the hurdles that were in our way for immediate communication. We were able to communicate with our docs. We were able to get that information on our handheld. We were able to go back and forth and have the questions answered that we needed in order to get the procedures done. So many times I would say that there's a great idea, but the implementation is just complicated. This was one where it's a great idea and the implementation was just easy. I always say, don't let hurdles get in the way. If you want to get from point A to point B, you got to run around the track to get from point A to point B. The best way to do that, the quick way to do that is don't run over the hurdles. And so, what we did was we said, okay, we have a lot of hurdles in our way. Historically, what's the best way to run around the track without having to run over the hurdles? And that is I reach out to my electrophysiologist on the handheld. I get an immediate response. If I have a case that needs an implantable loop recorder or an external monitor, I get that immediate response from the provider. Sometimes he or she may say, okay, working on scheduling, will the patient be here tomorrow? If yes, okay, I'll do it tomorrow at 8 a.m. Or if no, I'll do it today at 5 p.m. I'll jump in and just say that 2 days ago, we had a case where we requested an implantable loop recorder and Dr. Su did it in 2 hours from the time we requested it. So that was pretty great. So greatest benefits. Number one, removes the hurdles. Number two, of course, it improves the ability for us to get the procedures done that we need done. I mean, think about it. Prior to Viz Connect implementation, I told you, I was able to get the procedure done a handful of times within a year. I can't remember a time where I was able to get it done prior to discharge from the hospital. Now, with the Viz Connect solution, I get less than 2-minute response time from my EP specialist. I get an average of less than 1 day for implantation of the ILR or placement of an external monitor. We used to do a couple a year, and now this last month we did 13. And so, the concept of getting the procedure done that you need done is important here, raising all boats, whether it's an implantable loop recorder from company A or an external monitor from company B, C, or D, it doesn't matter. The point is, if I need a procedure done, my patient needs the procedure, getting it done quickly is important. And as I said, we did 13 last month, so it seems to be working. The third thing is the one that might take a minute for me to answer, which is what I call respect for patient autonomy. And this was the unexpected part. So I used to live in a world where we did serial processing, as I said. We would do an external monitor, we would discharge a patient, eventually do an implantable loop recorder, because we didn't even fathom that there could be a scenario where there was a different solution. But now, knowing that I can get an implantable loop recorder quickly, I have the luxury of having respect for patient autonomy and going to my patient and saying, hey, Mr. Smith, I have two options for you. We can put this external patch on and then, we'll follow it up as an outpatient, or we may need another one or another one or another one, or we can just do the implantable, but that would have to go under the skin and it, is more of an invasive procedure. And surprisingly, our data is showing that 50% of the time the patients are opting for the ILR, which I never thought that they would do, but in retrospect, it makes a lot of sense, right? Set it and forget it, put the device in, let me, go about my business. And I should have known better, but have respect for patient autonomy, let them make the decisions in order to advocate for their own care. And then the last thing is the most important one, which is that it just improves care, right? If I'm going to get a handful of implantable loop recorders or external monitors versus getting them anytime I want, quickly and easily, I'd rather have the monitoring, and I'd rather give the patient the opportunity to have the monitoring, to find the AFib that is so far occult or cryptogenic, and improve the patient's care by finding those AFib or aflutter moments.
Thank you so much. Dr. Su, would love to hear from you. What are your thoughts on the impact?
Well, that's pretty easy to answer. I think the impact is profound. Let's just put it that way. For providers, communication is seamless, basically from neurostroke to electrophysiology. And then communication back is also seamless, easy, simple to use, doesn't require really training. Keep in mind, as proceduralists, procedural cardiologists, electrophysiologists, we're scrubbed into procedure oftentimes, and having an efficient communication mechanism where the ask is clear and there's a notification waiting for us, or that we can have somebody help us with, is really important, and is what Viz Connect has allowed us to do. Really has allowed the EP physician to understand quickly and efficiently what is of utmost importance and what is the ask from neurostroke. I think from our experience for the patients, really the coordination of care for really busy physicians who are trying to take care of these acutely ill patients that should be communicating but have a difficult time finding time in the day to communicate has been really important. Life happens, and reduce time to how long it takes to get to a consult, the increase in consults that are seen is still really important for the patient. And really also being able to offer the right option for monitoring for patients is really important, I think, in order really to deliver the optimal care for them. Patients are having their monitoring delivered acutely at the time of their stroke, either on discharge or during their hospitalization. So these are actionable time frames where patients will get really what they need, which is basically monitoring for atrial fibrillation when it's desired by our neurostroke colleagues.
Thank you. Dr. Meyer, back to you. Can you talk about how the technology is really changing the standard of stroke care?
Sure. Let me go back to the original VIS implementation just as an aside, because the analogy is the same. There was a fellow working with me at one point who happened to be here during that year where we switched from the old way of doing things to the new VIS way of doing things. And in the old way of doing things, we would have to call the transfer center or call the neurointerventionist and find out what radiologist is on, figure out which bed the patient needed to be in, talk to the nurses. There were so many things we needed to do. And then we switched to the VIS solution where everybody was on a single thread. And I will remember forever her phrase to me was on January 22nd, after we went live on 2021, she said, life-changing. And that was for our original VIS implementation. And I would say with VIS Connect, it's similarly life-changing in that it has now become our standard of care. It is no longer okay for us to send a consult hoping it goes through the chain to eventually get to who needs to get it. If we need an external monitor or an internal monitor, we reach out using the VIS Connect platform, get our answers immediately, have a communication with the specialist. It's just our new standard of care. I could make it more complicated than that, but I don't think we can live without it at this point.
That's great. Thank you so much. And I think we've heard now the impact that we've seen from the standard of care in neuro overall. Dr. Su, can you talk a little bit from a clinical management perspective, what other cardiology disease states would benefit from this type of technology, where we're looking at a combination of AI and care coordination tools?
Yeah, for sure. VIS Connect has really opened our eyes as cardiologists, electrophysiologists, that if we can provide better care and better service to our stroke colleagues, can't we do the same in other cardiology disease states and for other doctors that need our help? Really, some of the disease states that come to mind for myself as an electrophysiologist, cardiologist, would be areas such as, number one, heart failure. These are complex patients where care coordination, communication, management are key. And so I could see a tool such as VIS Connect or anything in that realm being quite helpful for these patients. Number two, another disease state would be hypertrophic cardiomyopathy. Could early detection with an EKG or echo with AI and used in this manner really help to detect this life-threatening condition early, or start a referral pathway that perhaps even a human cardiologist may miss? That would be really life-changing for a lot of patients and physicians, I think. Number three, other cardiac disease states such as cardiac amyloidosis or aortic stenosis. Again, could an EKG or echo detection be better than, say, an expert cardiologist? Maybe many of us are worried about that, but I think that using these tools shouldn't worry us. They should help us in ruling in or ruling out a disease state. And then number four, back to atrial fibrillation, which is a topic we've been talking a lot, or looking for atrial fibrillation. As an electrophysiologist, could just a simple EKG or AI tool to help coordinate the care when an EKG in a care coordination pathway shows atrial fibrillation? Could we start getting these patients treatment for rhythm control, stroke risk reduction with oral anticoagulation or the left atrial appendage occlusion? Maybe we could start a care pathway that for the patient to see a cardiologist or electrophysiologist just based on an EKG. And these are the areas in cardiology that I see this tool being profoundly useful in the future.
Thanks, Dr. Su, for that. Dr. Meyer, I'd like to kick that question back to you from a clinical management perspective. What other areas do you see the benefit of this technology?
Well, sure. I think that, obvious in acute stroke, we're using it for hyperacute care. We're using it now for cardiology, electrophysiology. I certainly think that the use case for other neurologic or non-neurologic maladies are certainly primed, like aneurysms, subarachnoid hemorrhage, ICH. unrelated to neurology, pulmonary embolism, aortic imaging. Personally, I have an interest in seeing this move forward for PFO closures because a lot of strokes could be attributable to a PFO as well. So be it in cardiology or external to cardiology, external to stroke. I think there's a lot of potential applications for this.
Thank you. I want to thank you both so much for your time today in that discussion. While we were going through the question and answer section, we had a lot of Q&A actually come into the chat. We'll do our best to go through and answer them. We may have to send answers via email if we don't get to all of the questions, but a couple that came in for you, Dr. Meyer, start with you. What are key considerations that you considered when evaluating AI workflow solutions for a health system like UCSD?
Well, for me, it all starts with, does it work, right? I mean, does the system that you're considering do what it is you need it to do? The second, which is interestingly, not enough due diligence is paid to, in my mind, is where's the data that supports that works? For instance, for our original Viz implementation, I told you 32 to 39% improvement in our neurointerventional times. That's the data for Viz, what I call Viz Prime, or the paper is called Vision, just recently published. We have IRB approval to assess Viz Connect as well. We actually call it Connect in our IRB study, coordinating options for neurovascular patients needing electrophysiology consults and treatments. So that's where we're monitoring Connect. And we're measuring all the things that I would want to know, like how long does it take to get the consult? Where's patient satisfaction? What about provider satisfaction? How many procedures are we getting done? So we want to see all of the data, and hopefully, I'll be able to publish that after due time. But I would want to see some data if someone came to me with a new widget to say, hey, show me the data that supports that it works. The other thing is what I call the other key consideration is what I call the shiny penny moment, which is, everyone has a new widget, everyone has a new idea. But the question is, does that new widget or does that new idea result in improvement sustainably? Is it going to work later after the excitement of the shiny penny moment has worn off? And similar to our Viz Prime implementation, we have a abstract that was accepted just this last week at the International Stroke Conference called Vision S, which is for sustainability, and it showed that even after 17 months of our original implementation in the hyperacute stroke world, the KPI results were still just as good. And again, I would say key considerations for me are, does it work? Does the data support that it works? Does the data support that it works sustainably? And of course, I'm sure a million people will be interested in things like security and encryption and cost, but I think those are obvious answers to the key consideration question.
Great, thank you so much. Another question, I think Dr. Meyer will have you answer this. What is the key factor that has made this successful for you around the AI within your health system?
So this is what I call the secret sauce question. What is the key factor? What is the secret sauce? Why does it work? I'll keep it simple. It just works. It is a simple process. It allows me to communicate directly with my EP specialist. There's no learning curve. I didn't have to go out and train a million people on how to do things. Particularly with Viz Connect, my team is using it more and more over time, not less and less over time. Important note here that when your team uses a product more and more over time, not less and less over time, you have something that works, right? Because you don't have the change management moment or the education moment to continue to get people to use it if it's not working. So we set it, we forget it, people are using it, it's working. And as I mentioned, there's no hurdles that are getting in my way, it just works. So I think as far as the key factor question goes, I always say a successful healthcare tool needs to do three things. One, it needs to make my workload better. Two, it needs to make my day easier. And three, it needs to improve the care for my patient while doing number one and number two. And that's what this product does. It's as simple as that. For me, it's a win because of those measures.
Thank you so much. Dr. Su, this is actually a great question that came in for you. What has been the impact on your cardiology consult volumes pre and post Viz?
Sure, let's just take Viz Connect and talk about the impact that communication tool has had with our consults in regards to implantable loop recorder volume, say for cryptogenic stroke from our neuro stroke colleagues. Before we implemented VizConnect, we were getting consults for this exact question, probably 0 to 1 time per month, I would say. And our numbers now are clearly much higher, probably just last month around 10 to 12 per month in regards to this specific question for consult. So just sheer number wise, one could see how cardiology consult volumes for a specific question has increased multiple fold.
Dr. Su, another one for you. Do you think the challenges that your department faced are representative of most programs, especially those in large, comprehensive, well-established comprehensive stroke programs across the country?
There's no doubt that the challenges we face in San Diego are pretty generalizable to clinical care. I think in the United States and around the world, there's no specific issue or problem here that I think physicians and collaborators are not experiencing it in different parts of the country and different institutions, academic, private, no matter where these physicians are treating patients. Getting clinically busy physicians together to communicate is very, very challenging. We all have so much to do in the day. We all desire so much to take best care of our patients, but getting us together in the same room certainly is almost impossible, but certainly getting us together even to consult and bounce ideas off each other and getting a patient the care pathway that they need can sometimes be challenging. So making it simple and easy on a platform that requires no training is really, I think, important, and that's really what VizConnect provided.
Last question, I think, for you, Dr. Su. Is it likely that the type of technology will catch on more broadly with cardiologists to streamline care pathways within other health systems?
Yeah, it's almost with certainty that our experience with this type of technology, VizConnect specifically, has, I think, opened our eyes to other care pathways and has had us share our experience with other colleagues at different institutions. Look, EP is a pretty procedure and service-oriented subspecialty. We really rely on our colleagues to seek us out, to identify patients that are having issues that are related to arrhythmia, such as atrial fibrillation, so that we can therefore use our subspecialty expertise to help these patients. But if they can't find us or that they can't communicate with us, then we can't help. We can't, find these patients a lot of times. We don't know they exist unless they come in with a complication or an issue such as stroke. So we can't help. So when something like this tool is simple and effective, it's only natural to think of ways in which our subspecialty electrophysiology can help with other disease states or care pathways, such as with cardiomyopathy, myocardial infarction, or other arrhythmia states. And that's where I would see the future.
That concludes our webinar. I would like to thank everybody for joining us, and a special thank you to Dr. Meyer and Dr. Su for making this such an interactive discussion. I really enjoyed it. Thank you so much.
Thanks for having me.
Thank you for your time, and thanks for having me. It's really been a pleasure.
Thank you everyone so much for your time today. If you would like to learn more about Viz, you can visit us at viz.ai. You can also go to the handout section on the left-hand side of your screen where you could find the slides that were reviewed today, as well as a link directly to our website. Thank you.